that. So this is technological advances have reached a plateau. Very big advances in radiation oncology. You can use CT guided radiation, MR guided radiation. I'll show you some examples. So the advances are incredible. So be hopeful. If you don't have that kind of technology, you will get it one day, but you should know there is one before you get it. Next one. This is, we use SPRT. I'm sure they are using SPRT here. Lung cancer. Instead of 7 weeks of radiation, 4 or 5 fractions, you can build the lung lesion. It can be a pancreatic lesion, liver lesion, lung, pelvic metastasis, anything. That's one way. Next one. This is the same patient with the lung cancer at 5 years. No evidence of cancer because the treatment is so precise, stereotactic. The complications are minimal. The field you are using is very small, so surrounding lung will not get any significant radiation. So there are advantages. Precision treatment, less complications. Next slide. This is the game changer, which is the proton beam therapy. Only one center has this so far in Chennai. I was instrumental in establishing that. But more and more centers will come. It's very expensive. Government cannot do that alone. Maybe with partnership with private companies. The advantage you see here as an oncologist, you know, standard radiation goes through and through the body, whereas proton beam stops wherever we want it to stop, no radiation beyond that. So that is a significant advantage. The advantage itself will clarify where it is useful. In pediatric tumors, in central nervous system tumors, this is very useful technology. Next one. This I told you now, the new generation of technological advance is combining MRI with LINAC, one into one machine. So when you look, the beam is looking at the tumor when it goes through the tumor. When the target, when the tumor is off by a millimeter, the beam turns off by itself. So that is, I will show you some real examples. These are not animation or cartoons. They are real examples. And this India doesn't have, Europe doesn't have any of the machines. We have the first machine at our center. We treated hundreds of cases, thousands of cases. And now, one of the hospitals in Hyderabad will have this machine, combining MRI with linear acceleration. Okay, next slide. Kill that button open it. Go to the next slide. Next slide. Go to the next slide. Yeah. Okay, frame will okay, and press the button. Frame will, each one has a I just want to show you in real time how when the tumor moves out of the area of your planning, it beam shuts up by itself. Okay, go to the next slide. It's not important. Yeah, please at least turn the small clip of video on that bottom. Forget it. That's it. I'm showing some examples of lung, pancreas, prostate. When prostate moves, when you are giving treatment by 1 millimeter, the beam either gets adjusted to that movement or it shuts off. They call adaptive radiotherapy. Adapting to the location of the tumor. So that is the latest advance in oncology. Next slide. Next slide. I'm going to show you some few clinical advances, other areas. These are some of the things I want you to develop in your institute in India also. Go back, one more back. This one. This is a Time magazine story. Gentler treatment. Read the middle line where I put the yellow arrow. So what we would like to know, we know lumpectomy and radiation is standard of care, at least in breast cancer. But we just want to don't close the eyes and then keep on doing the same thing every day. Standard radiation 6 to 7 weeks. Patient has to come, especially from the villages to Guntur. Can we condense the 6 to 7 weeks into 5 weeks, 4 weeks, 3 weeks, 1 week, 1 day? That's what we did in the Sloan Kettering and Cornell University. 6 weeks, 5 weeks is as good as 6 weeks. Precision is important. 3 weeks is as good as 5 weeks. Precision is important. 1 week is as good as 3 weeks. 1 day intraoperative radiation with balloon brachytherapy is equivalent to 7 weeks of radiation. So once you think in your mind you reach the plateau, you never reach a plateau. There is always room for improvement. So more and more patients come to us to New York, flying from other countries, other places, because the treatments are so simplified. The cure rate is not compromised. The complications are minimal, but the time is condensed to a very short period. But precision and teamwork are important. So next slide. What will next slide? Next. Yeah, from 6 weeks to 1 day. In selected patients, in a small lesion, when they do lumpectomy, we give radiation right there. That's all the patient needs. If there is a slightly bigger lesion, we use a different technique, 1 week radiation technique. So those things, be innovative. We are always, I have no time. Patients are too many. Every center has the same problems. But how do we make progress if you do the same thing every day? Next slide. The same thing with prostate cancer also. We devise so many good treatments. Good treatment where the treatments can be condensed into 1 day or 1 week instead of 7 to 8 weeks of treatment. Next slide. Next slide. Go to the next one. Next. The cure rates are maintained. Whatever we introduce new, we always make sure that cure is not compromised. The quality of life is not compromised. Only thing is condensed treatment from many weeks to 1 week or 1 day. Next slide. Even Mayor of New York came for treatment to me, for the simplified treatment, because he has a busy schedule. He cannot come every day for 6 weeks, 7 weeks treatment. So we gave him 1 morning brachytherapy implant into the prostate. He went back to work in the afternoon, and he is alive 18 years later. You see his name, his photo on the TV when you turn on CNN or other American channel. Next slide. The other way I want you have a nice HDR machine here. The micro source. I will give you a little half a minute story how I developed HDR. What you see is my research done in mid-70s, the machine you have here. I was doing post-graduation. I was rotating from Osmania to Cancer Hospital there. This is in early 70s. And Dr. Professor Qureshi was the professor for me. He said, go and give pencil injection to CA cervix patients upstairs. I said, they all have radium inside, radium. I told him, if you stand behind next to a patient with radium, you get tremendous exposure. And you are asking me to stay in the center of a room where there are 12 patients in the same room with radium. I said, I will not do that. At least, you must be crazy even to ask me that. So that made me completely aware of what's happening. That's not the way to do it. So the next year, after my MD in Osmania, when I went to New York to Sloan Kettering, I decided I had to change the whole thing. This cannot be the way we have to practice cancer of cervix treatment. So we have put together a machine called remote action order, where the micro source, there is a iridium micro source in that, is moving out and in by a microprocessor control. So it goes out, radiates the tumor and comes back. You are not seeing the source, you are not touching the source, it's all done remotely. Patients get radiation only to the cervical lesion. Nurses won't get any radiation because when they go inside the room, the machine is off. So that machine is remote action order, which I introduced in mid-70s at Sloan Kettering. Now it is used in every single oncology department around the world.
Wow.
In China, in Russia, in South America, Canada, Europe, every department has remote operator. So if you have the intuition or you have the capacity to expand more, you can use that in esophageal cancer. You can use that through prostate cancer because the same source. How you introduce through channels, needles, or whatever is your brain power. So we use that esophageal, head and neck cancer, nasopharyngeal boost, everything, and gynecological cancer. And endometrial cancer, post-operative, invariably, the standard of care I published in the 70s is now used across the world. How to prevent vaginal recurrence in endometrial cancer. We use in this machine. So that is the HDR, different. This intraoperative brachytherapy, why I am mentioning that is, even though you don't have sources for intraoperative, you can put catheters, surgical oncologists, very cheap. You can put catheters and then connect to the machine, intrapost perioperatively, second day, third day. Give boost treatment, pull the catheters out, easy to do that. Close the wound, patient recovers, come back for external beam radiation. Instead of 7 weeks, make that into 4 weeks of radiation. So like that, this patient, go back. This patient, you see a superior cellulose tumor, big tumor here. It is invading the vertebral body, spinal cord, on the CT scan. And we remove the tumor, the margins are positive intraoperative. We place the catheters, gave the radiation, intraoperative, perioperatively, completed radiation, post-operative radiation. This patient survived 10 years. This is the beginning of my study in mid-70s. Even though it's a single case report, I published that in JAMA. JAMA won't accept usually single case reports. That paper was translated into all languages of JAMA around the world. Japanese, Chinese, Spanish. People really were stunned. Even though it's a single case report, you showed that these techniques are possible. Otherwise, look at this spinal cord involvement. Patient would have excruciating pain and would have died a miserable death. This patient died of heart attack, not cancer. Next slide. Wow. Next slide. Next. Okay, this is the same another patient, lung cancer. We resected the tumor. The tumor is here, whitish. All the rest is the normal lung. And margins are positive. Same technique again, next one. Yeah. This is another technique I designed where we have the availability of micropellets, very low energy micropellets. You put them in a microwave mesh and place them in an intraoperative bed. A positive margin becomes negative margin because there is a slab of radiation. You are basically expanding the surgical margin with this product. These are all introduced by us. Number of centers, I don't know, they are available in India also. Pellets are available, the only thing is you have to put together the team. And you can cure an incurable patient. You can make an unacceptable cancer resectable. You can make a useless surgery into a useful surgery with this thing. Next slide, please. This is published by us, by me, in many journals, and a lot of my fellows, doctors trained by me, use this technique all over the world. And I'll show you one example where this technique became handy. Next slide. In this gentleman. He came from AIDS. They are diagnosed with lung cancer or past president Sanjay Reddy. Lung cancer. He came to me and he had a lesion. The problem at that time was he was a chronic smoker. Anything you do, lung resection, he will not withstand that. So we designed a new technique intraoperatively like the one I showed you before. And we resected as much as we could resect very quickly because he cannot withstand anesthesia. And placed those intraoperative pellets with that mesh and all that we designed. And he survived 18 years without lung cancer. Without lung cancer. And he died of other causes. And I used to invite me to Bangalore where he finally resided at that time after presidency, and he was so happy that with a simple treatment we could treat him. And perhaps what the AIMS guys did a wise thing, sending him there, because these things are not available in India. Next slide, please. This is another glorifying example, most happy example. A 25-year-old kid with fibrosarcoma, resected 5 times, radiated 3 times, still has tumor. So what do? He was scheduled for amputation, disarticulation, 4-quarter amputation at Harvard Medical School. And he came to Soul Catering, and I'm very well known in America for taking up complicated cases. And I treated him with intraoperative resection and the brachytherapy. Next, you can see here, next slide please, next slide. You can see the healing, the hand, not at 10 years, 25 years later, the hand is fully functional. And why I am showing, he is holding a pen. Why I asked him to hold a pen? Because his compressor function is intact. He can hold it. So whatever you do, the organ should be preserved and the function of the organ should be preserved. Otherwise it becomes a useless exercise. So this is what he is now working as an engineer for state of New York. Next slide, I think we are coming close. This is another, any gynecologist in the group? No.
Okay.
Okay, good. This will be, I think, last but one example. This 50-year-old came to me from Israel. They did hysterectomy for cervical cancer. She went to UK to get radiation because margins or other reasons. Got radiation, and they said we cannot do anything more because it will take pain kills for 6 months and you have only 6 months to live, because they could not do anything. Look at the tumor here. For those oncologists, you can see the tumor here, recurrent tumor. With that kind of recurrent tumor, it's difficult to salvage. She had surgery, hysterectomy, radiation, all that. And she went to all major medical schools, centers in America. Finally, everybody said, go to Sloan Kettering. So she came to me, and we never give up on patients. We try the best. You have to, again, for people who are going to take up oncology, you have to look at the biology of cancer, individual. This patient has hysterectomy, radiation, and 2.5 years passed by. No evidence cancer anywhere. All this cancer negative. Then you have to think, this is only locally aggressive tumor. It's not metastasizing to liver, lung, bones and other things. So you have to design something locally aggressive. We designed a locally aggressive treatment. It's a very precise treatment. Very, very precise treatment with the team. And she was cured. She was cured. All CAT scans are negative. And I'll show you one date. How long ago was that? Last year CAT scan negative, past year negative. Look at the date, you may not be able to see. 1987. 1987. She continues to do that. She sends me New Year greetings every year from Israel, Tel Aviv. And she established a fellowship on my name in university there. And she wrote me last year, this beginning of end of last year, greetings. And she said, Dr. Nori, we celebrated 60 years of our wedding anniversary. 60 years of our wedding anniversary. I was so thrilled to read that because it makes you feel good. The next sentence, you have made me even feel better. Even very excited. We celebrated 60 years of wedding anniversary, 30 years of which is given by you. As a physician, that's the most gratifying, most